everyone, and welcome to ABC's of Anesthesia. My name is Lahiru, and I've got with me today Dr. Ki-Jinn Chen. Now, it's just been really great that I'm at the Darwin ASA NSC conference at the National Scientific Congress, and got a fellow YouTuber, so Dr. Ki-Jinn Chen. He is actually an MBBS with honours, Master of Medicine, but also a FANSCA, which he got the qualification whilst in Singapore, and also a fellow of the Royal Canadian College of Physicians. The reason he's very interesting to us in ABCs of Anesthesia is that he does a lot of ultrasound-guided regional anesthesia. So he has research interests in acute pain, regional anesthesia, and ultrasound. And he has an amazing YouTube channel, which a lot of our trainees get so much value out of, which is the title of which is his name, Ki-Jinn Chen. And I'll put a link to that in the story notes. So welcome, Ki-Jinn.
Oh, thanks very much, Hiro. It's a great pleasure to be here in Darwin and to meet yourself. I must confess, perhaps having the FANSCA a little bit behind me, I hadn't realized you had this great channel with all the exam resources, but I've had a look at it. It's fantastic. I've subscribed.
Oh, thank you so much. Every subscriber counts in the YouTube world, I think. But it's funny because I think, at least with my journey, it literally is just teaching the basics of anesthesia. And so at a certain age group or experience level, no one's probably heard of the channel because it is for juniors to kind of learn the basic skills. But how did you get started on firstly the YouTube journey?
Well, I've been involved in teaching regional anesthesia since I joined Toronto Western Hospital back in 2008, really. And not long after that, I was put in charge of the regional anesthesia fellowship. Mm-hmm. And as an introduction to all the fellows that would come every year, I would give them a series of introductory lectures on the basic blocks that we would do at Toronto Western Hospital. And it got to a point where I was giving the same lectures again and again. And then I thought, maybe this would be a little bit more efficient if I recorded it. Plus also I realized, and this is something I truly believe in, is that it's really hard to absorb everything on the first go. Yeah. And to have a resource that people can go back to and reinforce in that sort of cycle of learning as they do each block is tremendously helpful. And so this would probably have been about 2014 or 15. YouTube had become this established thing. And I actually have to credit one of my fellows at the time, a chap called Herman Sembi, who had come over from the UK, and still continues to be a great educator. He was the type of guy who'd put together courses to help people pass the FRCA in the UK. And he was actually very interested in producing videos and hosting YouTube. So he kind of put me on to that. Yeah. And I thought, I'll just record the slides I have and put them up there as a platform that people can access readily. Yeah, wow. And then it kind of just grew from there, really.
How long would it take you to make one video?
So currently, it would take quite long. And I think you probably know that a huge amount of work can go into making a few minutes of video. I treat it very much as a creative endeavor. I think like you, I quite enjoy the process. But probably a good 20 plus hours might go into making one video.
I was worried that you're going to say 20 minutes. I thought that's pretty fast. No, 20 hours. That's a long time. And I would kind of highlight the quality of the stuff that you're putting out there. That's the thing. It's 20 hours, but then it's there forever. Yeah. It's an amazing investment, especially if it's a good video that people can just keep watching over and over again, I guess.
And I think, just for people who are listening, these are basic principles that for me anyway, I wouldn't say I'm a natural born presenter. It's something I have worked hard to get better at. A lot of times by observing people who are good presenters. You know it when you see it. Yeah. But I try and sort of say, what actually makes them so good? And I think ultimately it's all about a story, right? Yes. You're telling a story. There has to be an arc and the central message. And I think storyboarding, whatever it is that you want to communicate to people, is important. That is the first part, and then thinking about what that would look like, and in essence, scripting it is so all that is like the front end work. Yeah. And then designing the content
Yeah.
other bit, and then editing, right?
Yeah, and yeah, it's definitely a massive amount of work. Now the videos I've seen, you don't have your face on there at all.
Yeah, and that's because it grew out of
Yeah.
slide presentations, and
Mhm.
I almost deliberately do that so that people are focusing on the slide content.
Yeah,
They
okay.
don't need to see me talking.
That's interesting. I've always thought about that. Like, I wish I, wasn't the face of a certain thing, because then you keep
Yeah.
a certain level of privacy. But I think people just engage so well with someone's face that have you ever thought that might be one of the things that it's like that interaction of a teacher who's there. It feels more personal. Have you ever been tempted?
Something to think about.
Yeah,
Yeah, I'm not entirely sure of that, but that's an interesting perspective.
Mhm.
Looking at what happens on the stage, I think there is a little bit of dynamism that comes out of seeing somebody,
Mhm.
but I might push back and say it's perhaps a bit more about the entire body language and not just the face.
Yeah.
So in the absence of sort of being able to gesture and do things, I'm not sure. It's
Okay.
different from an interview, I guess, where
Mm.
it's a little bit better when you kind of see people's facial expressions and you're changing things.
Yeah. Okay.
Yeah, but obviously, you find that you benefit from having your face, even if it's very, say, information heavy.
Yeah, I think so. I think there's just something. And I haven't seen the data on this, but I suspect that the channels that do really well have that kind of charismatic influencer type versus if it's just a slideshow. There's obviously a whole range of this, and obviously you're
Yeah.
very successful doing that. But
Well, I'll say that one of the people I really look up to, Jeff Gadsden, and the
Yeah.
Duke Anesthesiology channel.
Oh yeah,
If anybody deserves to have his face up there, Jeff should, but
Yep.
he doesn't, and
He doesn't.
he's tremendously successful.
He does very well.
I take comfort in that.
Yeah, that's right. Hey, so a lot of our audience are junior doctors, anesthetic trainees, or residents, and registrars. First of all, absolutely check out Ki-Jinn's channel. If from a regional anesthesia point of view, I think there's a few hospitals in definitely in Australia who are very, it really takes some keen individuals who want to do regional anesthesia. I'd say by and large, most hospitals in Australia haven't gone down the way of championing regional. There's just a few interested parties. Like a really broad question, but how would you go about learning regional anesthesia if you didn't have that system set up where you have a regional fellow and a block room and it's all just set up for this? How would you go about it?
Well, I think you have to, first of all, start small. And I'm sure you can find at least one consultant who you can tell is not entirely opposed to regional anesthesia and supports it. So they can be an ally there. And then hopefully they also have found their way into lists that lend themselves to regional anesthesia. In this day and age, I mean, I think the two that spring to mind in terms of surgeries that would lend themselves to it are shoulder surgery. I think most shoulder surgeons around the world wouldn't argue with the benefit of at least a single shot into scalene superior trunk block.
Yep.
They recognize that the surgery is painful. They recognize that the patients recover much faster, and particularly in terms of day surgery, same day discharge, there's no doubt it's facilitated by a block. So that's an easy win there in terms of, there should be very little opposition.
Yes.
The other one obviously is the total knee replacements.
Yes.
Even if it's an adductor canal block, that's a great block to cut your teeth on.
Yeah.
It's deceptively simple and easy, but get enough of those reps in, and you learn the nuances of scanning and in-plane needling. And then from there, you gradually build up. I think the important thing, I'm naturally conservative and perhaps even pessimistic by nature. So I try not to be too gung-ho. I would say, especially when you start out, you want to make sure that everything is a success and that your complications are kept to a minimum, because it's about building a sense of trust on the surgeon's point of view, as well as among your consultant colleagues. So
Hmm.
I've definitely been through that phase where, as an enthusiast, I just want to like block
everything.
moves, but sometimes it backfires.
Yeah.
You want to be patient and play the long game there.
Yeah, right.
But yeah, find an ally among one or two consultants. Try and get yourselves into lists that lend themselves to regional, where
Mhm.
the place of regional is unquestioned, and then use those as your sort of springboards.
I definitely felt like, as I was training, the easiest block to do under ultrasound that no one would disagree with was the fractured NOF having either a fascial yarker or a femoral nerve block. And I thought, oh, okay, I can get lots of ultrasound needling practice with this. So by the time it came to do the other blocks, I had hundreds of reps of just doing that. And it's a block, like, even back in the day, I guess most knee replacements got a femoral nerve block. So you could still do that, but these days probably not getting that for mobility issues. But yeah, I absolutely resonate with that. Once you've got the ability to needle nerve that skill set and that coordination, every other block just seems a lot easier.
Mm-hmm.
And that's a really safe area. Fascial yark is a very safe plane.
I agree. And then the sort of more modern alternative that you could throw in there would be a ping block.
Oh, yeah.
Also very safe, very effective, perfect for perioperative analgesia of a hip fracture.
Yeah, okay.
And again, nobody should really object to it because the risk is so low.
Yeah.
And the benefit has been proven in various studies.
Yeah, okay. And on that same theme, so let's say you get lots of reps, you find an ally who's happy to supervise you as a trainee, you get lots of reps in these blocks. What's the next stage? I mean, I remember actually just going through one of your mentors, I think, Vincent Chan, who one of the most published ultrasound regional anesthesiologists in the world. usra.ca is the website. I feel like I learned so much from his website. I would just go and read the book, and that's how I'd learn the pearls or the pitfalls or any particular block. Do you have a method by which you could essentially learn the nuances of things?
So, well, without meaning to plug my channel, I think a lot of the focus of my more recent work has been to try and communicate some of those nuances that I've picked up over the years of observing trainees, because I think there's lots of excellent basic videos out there that give you the fundamentals of any one technique. It's one of the reasons I have, for example, videos on fundamentals of scanning and needling, because there are certain things that it's only when you get your hands on, you've done a few, it's like, tilting the probe. It's not intuitive to people who put it first on, and they're just like sliding this thing back and forth, and they're fiddling with the gain, not realizing that just these subtle changes in tilt will like make the target light up, and they'll recognize the nerve now. The finesse of handling a needle in order to see it, recognizing, for example, that accepting that you can't always see a needle, but you can usually localize it. It's quite important terminology for me. Visualizing or localizing, yes, hydrolocation, but tissue motion as well.
Oh, yeah.
Like as you move that needle, understanding what are safe movements that don't carry the risk of needle trauma. Those are little things that can help you sort of get to the next level of tracking your needle tip, putting it in the right place, getting location.
That makes so much sense. I feel like no one really told me these things. I mean, hydrolocation it seems very obvious and very useful, and you can Doppler it as well to be absolutely sure it's there. But I love the fact that the body just has planes, fascial planes, and you can see the tenting. Where that needle is, and when you just do that. I don't know if this is the technique used, but that sharp jab. It's a millimeter of a jab. It's not much, and it's not angled at the nerve. It's away from the nerve body. Then it punctures through and you see the release and you I'm in now.
Yeah, exactly. It's that tenting followed by the little spring back or release. Actually, just a word there.
Go.
There are some of my colleagues who advocate, like when you're on the fascia, to kind of jab through it. I'm more of the constant forward pressure. Let it stretch, but you're waiting for that spring back and the little pop that you feel. And that, because you've been pushing forward with control, you're able to immediately back off. Whereas the jab can sometimes be a little bit more uncontrolled.
Actually, this is a really good point. I'm going to talk about in this chat some of my techniques, and I would actually, and you're probably 100x more in terms of regional blocks than I've done. So I would just like you mentioned that, I would really like you to, just like you've done, tell me how you would do it and the reasons why, because I think that'd be incredibly useful. I'm a consultant anaesthetist with 10 years of experience, and I do enough regional that I'm very comfortable, but I feel like the subtlety of when you've done thousands or tens of thousands is very valuable. Do you find, so I've found that when I tent it, let's say without the jab, it stretches to incredible amounts.
It does.
But you just aim away.
You just aim away, and you just
keep going.
You just live with that little bit of discomfort, stretching, but you're just waiting for that. And more and more, my focus starts to turn away from the screen to the feel.
Yes.
I don't know how many of your trainees will find that even something like an intravenous, you do enough of them, you'll get to a point where you've actually entered the vein. Because there's just this subtle change in the feel.
So subtle, isn't it? Yeah.
Right? And it's the same kind of thing that you're looking for. Or an epidural, right? If you're part of that stepwise technique, there comes a time where you can almost feel the individual ligamentum flavum fibers sort of parting before your needle.
Yes.
And you're sort of advancing a little bit, checking it, but that same sort of tactile sense is what you can apply to a peripheral needle.
So you've got to develop that. So essentially, we're talking about fascial plane movement, hydrodissection, obvious needle localization, and technology in the ultrasound that allows you to do that, I imagine, but also the sensation.
Yeah.
If you can work on those things, that will go a long way to making you safe because you know where your needle tip is.
Yeah. So you're controlling that element of, both preventing mechanical needle nerve trauma as well as getting the needle into the best possible location.
Yeah. Excellent. Is there anything else in that space of making sure you can see your needle tip? Is there anything else you would suggest?
Don't forget that there is an element of alignment. Much as I said, there are times when you'll have to accept that this is probably the best possible image of the needle. You can also work on that bimanual coordination of the small sliding motion of the probe, while at the same time generating a little bit of motion. I always say a static needle is extremely difficult to spot.
Yeah.
So you've got to develop this automatic thing where you're just jiggling the needle tip. There's the jiggling in and out, and there's the seesawing, where you're rocking the hub up and down, and then the tip lifts up and down in the same arc as you're moving the hub. And that's where you're looking, because the tissues at the tip will lift, and nothing beyond the tip will lift. So I find this seesawing motion
I've never done that. So so seesawing is, you can see bigger movements, I imagine, and it's also safe because you're not moving it
and
into something.
It's very definite, because jiggling sometimes, in and out, there's a little bit of transmission of that forward jiggle. Whereas when you're seesawing it up and down, nothing beyond the tip will actually move. Yeah. So I find it a little bit more precise sometimes in telling me where I am.
Oh, that's interesting. I found it. I'll absolutely use that technique next time just to see where I am. So in terms of safety, do you have any, I know I used to have this lesson of you'd always aim for the edge of say a supraclavicular nerve bundle. It's quite, it's almost well described in a sheath.
Yes.
You never aim for the inside the sheath. It's always to the edge of it.
That's right. Just be at a tangent. The principle is be at a tangent to anything you don't want to pierce.
Yep.
And the bluntness of the needle will just lead to it sliding away.
Okay.
And, I come from an era when we still did transarterial axillary blocks. And at that time too, they had just introduced block needles, and there was a vogue about use a block needle, a blunt block needle, because it's safer than nerves. But you try and apply that to a transarterial technique, you would never be able to pierce the artery. No. You'd be fixing it to your fingers and driving straight there, and the artery would just slide away. And we even see that with veins, right? Like IV cannulation. If you don't stretch that and fix the vein, even that sharp stylet won't necessarily pierce the vein cleanly. Yeah. So you can use that in your favor with the block needle. which is why, vessels in the way after a while, much as you need to be cautious, you'll find that they aren't really as much of a threat as you think they are, because with slow, gentle motions, they'll tend to slide away from your needle tip, particularly, as I said, if you're approaching them at a tangent. And the same applies to a nerve.
Yeah.
So I usually find that what I'm trying to do is, in part of that pre-scanning before I put the needle in, is to identify the borders of things that I want to respect. And part of the scanning is to say, all right, that's exactly where the edge of the plexus is. That's where the edge of the nerve is. So I'm going to make sure that I'm aiming so that I'm at a tangent to the surface of that. And then as I get closer and you push forward, you want to recognize that that structure is rolling or sliding away from you. And that actually is a useful cue too as well, when you're not quite sure if this sort of blob in that mass is just connective tissue, or is there actually a discrete structure hidden within it. As you actually get to it and you probe, by probing, I mean pushing forward against something without necessarily piercing it. And I make that distinction between probing and piercing. And if you just probe, often you'll see, oh, there's something that's just like bobbing away under my needle. And that will often say, there is actually a solid structure there. Whereas if it just stretches, then it's probably just connective tissue. And you can then push forward and not worry too much that you're about to impale something.
It's interesting you said that, because that first point you made about when I do my scanning up and down, it's to be sure that my structures are what I think it is. Like if I can't see a good superclav view, I go to interscalian and follow the trunks and roots down. But what you're saying is you're actually going up and down to see the 3D orientation in your mind of where this structure is.
Yes.
And so that way you're not just working in a 2D plane, but you're working potentially in a 3D plane.
Yes, and I think that's what actually you're actually doing as well. And I think that you just not quite the same words, but I think by scanning up and down, you're building a 3D image of this cylindrical structure, right? It's not a 2D circle, it's a 3D cylinder.
Yes.
And then there'll be times when, say, the supraclavicular plexus, you're trying to identify the planes between superior and inferior middle trunks, and there will be maybe a plane a little bit more proximal where it's much more obvious where that is. And then you scan down, half a centimeter, maybe less, and it gets a bit fuzzier, but it can't have changed very much. And so you sort of carry that mental image from the first position down to the second, and you have a pretty good idea where that is. And it's that kind of thing. You're exactly. I think the serious one analogy I often use, it's kind of like you've got a pen light in your hand, and you're in a dark room. And you're only ever illuminating a little bit of that dark room at one point with the pen light, but you flash it around enough, and your mind creates these little snapshots that you put together.
That's really interesting. And I can imagine that makes it a lot safer. If I'm really aware that there's an artery just here, an artery just there, and lung kind of sliding around here, that is good to know. That is.
And then the next thing is, once you've got the fundamentals down of scanning and needling, if you want to learn any new technique, that then starts with a question of getting to know the anatomy. I would say the best regional anesthesia textbook that you can buy out there is the Atlas of Anatomy. Or, in this day and age, a anatomy app. One of those that you can 3D and you can turn it and swivel it and look at it. And really understanding that anatomy is key then to, when you put the ultrasound on, you can recognize and match up what you're looking at in these black and white images to what they actually represent. And that's how, to be fair, any of us along the way who sort of invented these new blocks and things, I can guarantee you we all started by going to anatomy textbooks, anatomy articles, written by anatomists, written by radiologists, who often have described anatomy for other purposes, but the detail that they provide there allows us to understand exactly what it is that we're doing and then adapt that. So it starts with the anatomy. Nowadays, as I said, most of the established techniques, you'll find some sort of online resource that
Yes.
will guide you to the basics. But you can never know too much anatomy relative to the block. It'll help you.
Is there any particular apps that you would recommend for anatomy or regional anesthesia?
I use Essential Anatomy.
Okay.
I think it's definitely good enough. I haven't really looked at anything else. I bought it ages ago, and it serves its purpose.
Nice. On that note, is there any? You mentioned anatomy as a way to, I guess, discover new blocks, and if you can think of, the evolution of tap blocks or the PEX blocks, adductor canal, rectus spinae, these are all because people know anatomy. Do you think there's any blocks that are still yet to be discovered?
Good question. I think that I think that you would probably start with a clinical application.
Yes.
And nowadays, I think it's becoming sort of how selective can I be?
Yes.
Right. Chasing small nerves.
Small variable nerves.
And then I think maybe those would be where the last sort of frontier is.
Okay.
The only reason I'm being a little bit hesitant and cagey is that I'm not entirely sure how clinically useful they would be. It reaches a point where, and I'm talking purely from acute pain.
Yes.
Where being too selective is not necessarily the effort involved is not necessary.
So Ki-Jinn, is there a block that you've invented?
Is there a block I invented?
Yeah.
Probably the first block I invented is I'd like to think the superior trunk we invented.
Okay.
Popularized.
That's kind of you say we, so that's
yes,
to share them.
My former fellow, who is now a very accomplished consultant in his own right, David Burkett-Laurent, who is practicing in the UK. So his name is first on our letter about the superior trunk block. It is actually just a letter in the CJA. But that was, I think, where we first described the concept of tracing the interscaling down to where they coalesce into the superior trunk. And just kind of like put that out there.
And that's the indication for that?
It really is anything to do with the shoulder.
Yep.
I say the superior trunk is an interscaling block, just that sonographically it's a very different target.
Yep.
And since then, other people have taken that and done actual research with it and shown that it's equivalent in efficacy with a lower, but not zero risk, but lower risk of perhaps causing phrenic nerve issues, particularly if you limit the value. So I tend to teach a superior trunk block, but mainly because I find it a much easier block for people because the target is brighter, more contained in fascial sheaths, a little bit more protected. So I tend myself not to do interscaling blocks, which is not to say that it isn't a valid technique.
Yeah. But once you've done this superior trunk block, that takes out the need for the interscaling in most circumstances.
In most circumstances. Yeah.
Okay.
Very occasionally, the superior trunk is really just there's too many crisscrossing arteries in an individual. Or one example I can think of in recent history was somebody with a really bad clavicular fracture and extensive supraclavicular hematoma that prevented us from getting any decent view of a superior trunk. So we went higher up to an interscaling.
Which is fair enough, really.
And I think I don't really like engaging in this, pro con, is this better, which is the best. And I think, from a personal point of view, and one thing is to be flexible.
Yes.
And that's really what I found the most exciting thing about ultrasound is that it gives you that ability to be flexible. You can look and, all right, this one's not working. Let's just look slightly in a slightly different place, and can we make it work? It also means as you get on, you don't have to stick to the, if you like, the conventional even needle approach. In plane, generally I think most accessible for most people. A lot of blocks can be done out of plane, and there are times when out of plane is actually ergonomically better. So being comfortable in out of plane technique
Mhm.
is something you should do.
Yeah.
And I always tell people that's actually what we do with vascular work.
Yeah.
You're always approaching out of plane.
Yeah.
So learning to track the needle tip
It's
in,
quite bad.
when you're doing a central line or a peripheral cannulation, arterial cannulation,
Yeah.
you shouldn't just, stick it in and not move the probe to try and track your tip. You should always try and track your tip there. And
Yeah. And the only difference is you want to get into the structure versus around
exactly,
the...
which is probably why people don't worry so much about tracking it. But
Well,
at the
yeah,
same time, you want to get into the structure and recognize that you haven't gone through it and out the other end.
Which is easy to do.
Yeah.
Get those tiny arteries. It's
There's still reports of pneumothoraces after an ultrasound guided internal jugular line. It's like, why should that ever happen?
That should, it seems like such a zero event.
Yeah.
It should be a zero event. Do you ever, let's say in the supraclavicular block example, do you ever go into the sheath and do an I don't know the right term for this. It would be perineural?
So what I think I would not advocate people doing is an intracluster injection. That's one of the terms that has been used in the literature, where your needle is within a trunk, and so that when you inject, you see the trunk expanding.
So let's say you've got, this is a good example of the supraclavicular view has a very high stroma to axon ratio. You've got lots of divisions, lots of opaque structures with the stroma, which is the white structures, and to go into that circumscribed, like a very nice supraclavicular view, to instead of going outside, which it would be my approach, a traditional approach, you puncture inside and give a dose of local anesthetic, which goes straight to those divisions rather than outside the sheath. Is that something that's done frequently or advocated, or?
I don't think it is advocated anymore. My colleagues, Laura Hiron Arango and Anahi Perlas, published not long ago in RAPM an article about the intertruncal approach to the supraclavicular block. And I think that is where most people lie now with how you should do it. But interesting historical fact is that when I first started regional in 2007, and we did a lot of supraclavicular blocks at the Western, I was told, stick your needle right into the middle of that plexus and inject and watch it explode. And we would say the exploding plexus.
And it will work amazingly well.
It worked
potentially for life.
So well. Then after a while, it's like, this doesn't feel right.
Yeah, okay.
And, we eventually refined that a little bit. The good news, though, is that I don't actually recall permanent neurological deficits occurring in that phase of our evolution.
I do. The reason I ask, I do have colleagues that do that. It's their routine. Smaller volume, goes in there. It's again in the stromal area. It's not a sharp technique that cuts an axon of any sort. And so I guess there's some level of safety, but again, it's something that if you're a trainee, just stay away from that. That's not for the training level.
The way I think about it is that just because something doesn't happen very often doesn't mean that it's the right way to do things.
No, that's right.
You don't get knocked down most times you're jaywalking across the road, but people do. People get knocked. So
It's said like a proper Singaporean. Can I ask you, and maybe hopefully we have enough time for this, but would it be possible to go through some of the major upper limb and lower limb blocks and give just maybe 3 of those pearls that you found, you wish you knew, this kind of higher level stuff?
Right.
So to start with interscalene, some. So
honestly, I think you start with the end in mind. So as a trainee, you want to have a block you do for shoulders, and then you want to have a block that you do for elbow down to wrist and hand. So when it comes to shoulder, I think that the choice is interscaling block or superior trunk block. Efficacy is the same. So pick one, and again, tons of resources out there. Recognize that phrenic nerve palsy is a common side effect, and the one thing I'll say about that is, barring a respiratory cripple, this phrenic nerve palsy I'm not sure is that concerning in a complication in clinical practice. Most people are not terribly affected by it.
You know, the funny thing, one of the first blocks I was ever part of, unbeknownst to us, as a trainee, we didn't know that the patient had a cardiac surgery that caused a contralateral phrenic nerve palsy. So this patient, as soon as we put the block in, couldn't breathe. We had to give him a GA straight away. Block was great, but he had to go to HDU because we just did not know that that was the reason why he was struggling. It was such a random thing that we would never have picked up because the patient didn't volunteer it.
Yeah.
But anyway, so absolutely. Phrenic nerve, not usually a problem.
Not usually a problem in
rare
a healthy patient. Yeah. Maybe your antennae should go up when they've had stuff done to them. Yeah.
So
I think those
interscalene trunk, phrenic nerve, that's the main thing to kind of be a bit concerned about.
Yes. Occasionally you'll get called because the patient's got this dilated pupil and their eyelids drooping.
Yeah.
And so, okay, it's the Horner. I forgot to tell you about the Horner syndrome, which, again, not invariably seen, but again, harmless. So no harm done if you forget to tell the patient about that. Then, when it comes to elbow to hand, you can really take a pick from supraclavicular, infraclavicular, or axillary. I tend to say that, once you've got some degree of competence, and then efficacy should actually be the same. It then boils down to, I think, side effects and complications. So, the full disclosure here is that I have colleagues who love the supraclavicular. They're very good at it. I tend to reserve it as a third line only because it is the one of those three, supra, infra, or axillary, that carries the highest risk of getting a phrenic nerve pulse. And notwithstanding my comment that it often doesn't matter, it's like, why knock out the phrenic if I don't have to? But more importantly, I've been caught out a couple of times because you get to this diagnostic dilemma sometimes where you've done a supraclavicular block. In PACU, they're either breathless or their SATs are low. And then you're like, okay, this is a phrenic nerve palsy, but can I be absolutely sure it's not a pneumothorax? And then, of course, you could scan the lung and make sure it's not moving, which reassures you. But a lot of times you find yourself anyway doing a chest X-ray. And then now you're giving the patient a dose of radiation, which maybe you didn't need to. So there is that element of a diagnostic dilemma. Now, there are times when it is the only block you can do because they can't abduct their arm. They've got a huge, big chest wall that makes the infra, difficult. So it remains a valuable technique. The other advantage that sometimes happens, which is both an advantage or disadvantage, it's a double-edged sword, is that the supraclavicular block will knock out the shoulder. So what it does is it produces complete immobility of the arm. So even if you have a fidgety patient, as sometimes happens when, they're slightly sedated, they don't often end up creating this motion that transmits down to the hand and annoying your surgeon. But again, that I don't see that as a huge push to, I must do a supraclavicular.
Okay, interesting.
I do favor infras and auxiliaries, and I think everybody should master an auxiliary because it is probably the safest and simplest of all the blocks.
Now, while you say that, I've got to say, when I look at the interscalene and the supraclav, it's just a beautifully, it's just such an obvious block. There's dangerous structures around, and there's phrenic nerve and the lung and everything, but it just seems so easy. Whereas if I do an auxiliary nerve, it's raising the arm up, getting the right angles. I've got the muscular cutaneous. I've got 3 points potentially of needle insertion to just make sure I get each of the points. Please correct me if you do a different technique where you just do a volume in that site. And I think generally speaking, I'd go for the supraclav or the interscalene for lots of things. But yes, definitely when it's a fistula, I'm going to do the auxiliary. That principle of the most distal site that will satisfy the block. So, for a safety point of view. What are your thoughts on that?
I'll say that supraclaviculars can be very easy, or they can be very difficult. And some of the things of course, you can always put the probe on and see. But I've seen enough where patients with short necks, patients with deeply scalloped supraclavicular fossa, actually imaging can be quite difficult. Or if they've got a lot of subcutaneous tissue, sometimes you'll find that the boundaries are quite murky.
Have you also found this thing where, like, I've got to say, the last two patients I've had some kind of fascial plane dividing what was usually a nicely transcribed set of divisions, and it's now two sets that I've got to puncture different sites to?
Well, that comes back to that intertruncal variation. Usually the superior trunk at the level of the supraclavicular plexus is still quite distinct.
Yeah, okay.
So I personally will do at least a dual injection technique. I'll put my initial bolus of local anesthetic between the inferior trunk and the first rib. That generally has the effect of lifting everything up. Plus, you get enough local in the plexus, and the different elements now start to be a little bit more defined. And then I put the other half of my intended volume between the superior trunk and the middle trunk at that point.
Yes.
Because that, again, that plane, as you pointed out, is usually quite obvious.
Yeah, okay.
And between, that dual injection technique generally results in a very high success rate. Very little sparing. Yeah.
In terms of the auxiliary, also just the vascularity of that region, sometimes there's just veins everywhere.
It comes back to what I said, which is I don't get too worried.
They move it around.
What's wrong with puncturing a vein in
That's true.
You're a healthy patient?
Yeah, it doesn't
do it all the time.
Just don't inject into it.
Just don't inject it. Exactly.
Yeah.
But puncture it, no big deal.
Yep.
And then a lot of times I said that blunt needle will just kind of like push past and glide past the vessel.
And it's probably good to clarify, we are not talking about hypodermic needles.
Yes, we're not.
They're not, these needles are like the Stimuplex, or I know some other brands out there.
Hyams, whatever that. All block needles are generally short level needles. Yeah.
And they're almost frustrating. I remember doing the local anesthetic and just so easily goes through the planes. I'm very often tempted to just keep going. You're going, I'm just such a beautiful needle nerve visualization. I'm just going to keep going with it and block. But I said, no, got to do the right thing and not put a sharp needle near structures.
Yeah. To be fair, I think there are some blocks where the ease with which a hypodermic cuts through things can sometimes work in your favor because you don't have to apply as much force. And so you actually attain a little bit more control.
Yes.
So in some nerves with the ankle block, the things that lie immediately sort of subcutaneous, it's actually, if you're going to do anything that suddenly involves a subcutaneous injection, actually hypodermic's fine.
Yeah.
And you'll struggle less because you aren't having to apply as much force.
Yes.
And that allows you to have that greater degree of finesse that we were talking about.
Yes.
So there are times when it's not a bad thing.
So we've gone through kind of the pitfalls or pearls for auxiliary plexus. Sorry, auxiliary approach to the brachial plexus.
Yeah.
Any tips for that?
The key landmarks, artery, and conjoint tendon. Because the one that everybody says they can't see properly is the radial nerve.
Yes.
But if you're looking at the conjoint tendon, the radial nerve is sitting on the conjoint tendon. And at a pinch, just inject on the conjoint tendon or just under the artery, and you will get the radial nerve.
Yep.
And often as you inject, it will show itself to you.
Yeah.
Even though you don't initially see it clearly before you put local.
Yes.
But as long as you're proximal enough, and the thing I say is you want to feel that your probe is pressing against the pectoral fold. Like you've got to be pushing up against their pec. If you aren't, chances are you may not be high enough. And then look for that nice slanting line that is the conjoint tendon, and that is the floor for the neurovascular bundle.
And I imagine your video on the auxiliary plexus block, that will have all the images and visualizations.
Yes, and I think I emphasize that point very much.
Yeah, good. Yeah, good. How about femoral nerve and the sciatic nerve approaches? Let's go with femoral nerve first. Seems like it's one of the very standard blocks that we've done throughout time, but probably less so now because we want to preserve muscle and mobilize quickly with our knees and hips. Any tips for that?
So you're quite right about it being a technique that's at risk of disappearing because everybody's so focused on muscle motor sparing. But there are times when it's a very, very useful block. So where quads weakness is a non-issue or not a relevant consideration, and the pain is actually coming from the quads or its related structures like patella tendons or the patella itself, the femoral nerve block is like the best technique to do. Again, the worry is that you will cause damage to the nerve. And there, it's important in the scanning survey scan phase is that you try and make sure you identify the borders of the nerve. It's a little bit of an anisotropic nerve. By that I mean you do have to engage in a little bit of tilting to really make it light up. But again, it's always sitting on the iliopsoas muscle.
Yeah.
So again, my
muscle.
video makes that emphasis. So look for the dark muscle and look for this oval hyperechoic structure that sits on top. And then respect it. I usually choose to just make sure I am entering at the lateral edge of it and not into it.
Yep.
And then opening up the fascia iliaca around it.
Yes.
And quite a lot of times the local will bathe it quite nicely.
Yeah, nice.
Yeah.
So you're definitely staying away from the medial edge where you've got the artery and the vein.
Yes.
Very much the tip of the triangle.
Yeah.
Yeah, good.
And then, with sciatics, most times now the role for proximal sciatic block has diminished. It's probably the block we do the least of.
Yes. There's not many operations really.
No,
I mean,
really, above knee amputations might be the one that springs to mind. That one is a difficult block. I would say that's something you do when you're a bit more advanced or really passionate about it.
I just remember doing a standard kind of 0.75, 20 mils, which was probably a bit much back in the day. And the block just lasted for 2 days. And I was terrified that I'd done some nerve damage, but one of my very competent consultants who did many of these blocks said, "Oh no, that's just the fat pad. It's just absorbed all the local. It's leaching out. It's a thick nerve. It's just local just lasts longer in this nerve." Yeah. Is that your experience as well?
That is. I think the popliteus and that's applicable to the popliteal sciatic nerve block, which we would often do for anything from below the knee, foot and ankle. Characteristically, it is a block that's known, for whatever reason, to have a much longer duration compared to the other ones. So you should warn patients about that. You should expect it.
Yeah.
There was a time in nerve stimulation blocks, we would actually routinely put 30 to 40 milliliters of local anesthetic. That's days before we would see things. And that could have been a factor. But now we limit it to 20 and we still see fairly prolonged blocks.
Yeah, okay.
Now, sometimes that's something you want, because if they've had complicated foot surgery and they are not expected to be mobilizing, they're in a boot, it's okay. Their foot is supported, and then they get the prolonged analgesia. You just need to warn them to expect that their foot will remain numb. So that's the main caveat, to prepare your patient's expectation. The other thing I would say very much so now with ultrasound is to look for that bifurcation. Again, this is with reference to the popliteal sciatic. Is to very much look for the bifurcation, because that is the sort of zone, the Y zone in between the two, is that safe part where you can pop the needle in without risking damage to the nerve itself. Yeah,
okay. I always thought if I block the two separate nerves, there will be less, it'll be a faster onset block. That's the other thing. I found it's a very slow onset block for the timing of surgery without the block rooms and all that. So if I have two smaller nerves, I'll block them faster.
But actually what happens is if you enter at the analogy is it's a pair of pants.
Yes.
And you're entering at the at the crotch of the pants.
Yes.
And what you'll see is that by the time you put 20 mils in, even less than 20 mils, the local has spread down both pant legs.
Yeah, okay. Yeah.
And so, whether you choose then to enter each pant leg separately versus going in the middle, I think you end up in the same place.
Yes.
Which also is the opposite. If you find that for any reason it appears easier to target them separately, that's perfectly fine as well.
Okay.
And that leads me to another point that I emphasize very much to trainees, is that during the process of injection, and you're no longer moving the needle, there's no need to hold the needle in view. What you should actually be doing at that point, as your assistant is putting in, you tell them, inject 5 mils, inject whatever. During that injection time, you should actually slowly scan proximally and distally along the nerve
Yes.
to assess the spread,
Ah, okay.
because it tells you, number one, that you don't have to reposition your needle,
Yes.
despite what it's looking like in the exact
Slice.
cut and slice that you've got the needle in. Sometimes it looks, oh, and everybody thinks you've got to get the donut.
Yes.
Scan north, and the fluid has done its donut. It's just done it higher up. And there's actually no need then to engage in repositioning.
That's fantastic. I've actually never done that as a
I
technique.
call it
Yeah.
sort of assessing spread.
Yes.
And you're just scanning the area while injection is occurring. But the second important thing it does is, so first of all, it tells you that your spread's in the right place. But the other thing I say is that at that point, what you're optimizing for is also the visibility of the nerve, because the thing you want to make sure is that the nerve isn't expanding.
Yeah.
Because there have been times when, oh, that thing is starting to blow up a little bit.
Yes.
Come back, reassess that needle. Oh, yeah, okay, you know what? I'm just a little bit too close. I've accidentally caught the curve. So you're doing two things when you're surveying. You're looking to make sure that the spread's going around the nerve, which indicates you're in the right perineal compartment, but equally so your emphasis should be, I want to be absolutely sure that the nerves aren't expanding.
Yeah, absolutely.
Yeah.
So Ki-Jinn, we're almost coming up to around an hour. It's been a great chat. And it's just flown by, actually. I actually really wanted to ask you, have you had any just real wins where you had this patient who, I don't know, you absolutely just had to get this block working? There was like no other choice, or this was the win, whether it was, some kind of chronic pain syndrome, or they had an, very high risk general anesthetic for whatever reason. Do you have any of those moments that you just look back on and go, oh, I'm glad I know this, very precisely?
Yeah. In the last few years, probably one of the most challenging ones was a lady with Eisenmenger syndrome.
Yeah, that'll do
who
it.
had baseline saturations of 80%. She was quite happy on that 80%. She had a hemoglobin of 210.
She was happy to be alive.
And she'd fallen and broken her hip.
Yeah.
And interestingly enough, she declined fixation, because everybody was telling her that you've got this tremendous risk of mortality and whatever. And she was a very stoic Eastern European lady. And she said, it was so funny. She said, I'd rather lie in bed than lie in a coffin. So you know what? I'm just going to suck up the 6 weeks of conservative management. But nevertheless, my surgeon said, you know what we'll do? We'll put in an external fixator.
Yes.
And obviously we decided that we would do that under a regional anesthetic. And we ended up doing a femoral fasciae iliaca block, and some local around the site of the pins. But she had really distorted anatomy, because she didn't have a normal hip. She'd actually broken it before years ago. Yeah, wow. But again, that's where, as I said, scanning and seeing lots is really helpful, because you just hone your ability to spot the patterns of anatomy. And so even when things don't quite look right or distorted, you have a pretty good idea of where things are.
Yes.
And this is where the experience part and just seeing and doing a lot comes in.
I think there's probably a period of time, probably 6 months in one rotation, lots of easier cases in a smaller peripheral hospital. And I'll just get the ultrasound out, and if it was a lower limb surgery, I would just scan up and down every single patient's arms, and if it was upper limb, I'd scan the legs, and just learn. That's your textbook right there.
Yep.
The patient consented to being scanned just for your learning, and suddenly you've just got lots of reps on the board without sticking a single needle in.
Yeah.
Yeah.
And I would say too, when you finish that block, if you have any time left,
yes,
have a look at some of the other areas around, and just most patients are very happy to let you have a look around.
Yeah.
Because there's very much this element of training your eye.
Yes.
It's the same with neuraxial ultrasound. I always tell people, it's not that you need to put an ultrasound on for your regular epidural spinal, but you want, if there's timing, you should do it.
Yes.
Just because you want to get the reps in of training your ability to quickly acquire images that you know how to recognize.
Absolutely. That's good. Thank you so much for your time. It's really opportunistic to be able to just kind of talk and record a podcast.
I know, right? You could do this for hours.
I know. We literally could. I mean, I believe you've already done with each of your videos for your channel, but it was so good talking to you. And yeah, thanks for coming to Australia, to Darwin, to be with us here.
No, it's a pleasure. And, to have met you. I hope we'll have an opportunity to see each other again.
Yeah.
And even collaborate and stuff.
That'll be great. Let's absolutely do that. So thanks to everyone for listening. Please share this with anyone who might be interested, and we'll see you again for the next episode. See you guys. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.